I think that we can now open the floor to questions and remarks. And Malcolm, you would like to be the first one. Please, we have to unmute Paul before.
So I don't know what time it is over in Dublin, but it's probably very different than here. This is Malcolm Cox. I wanted to take the opportunity of congratulating you for your new position, which we believe you've started. Is that correct?
Yes, Malcolm. I'm now the National Rural Health Commissioner for Australia.
So the question our table came up with was looking for similar examples to what you had done with the Flinders program that you described briefly in the United States. And of course, there are a number of them, the WAMI program, which you're well aware of in the Northwest, and the RPAP program in the center north of the country, sort of examples of rural health training along the same models of the LIC and rural emphasis that you've done in Australia. But the question is how you spread that across an entire continent. And given your new position, it seemed that a relevant question would, what are your plans to spread this model throughout the entire country, Australia being the country we'll be interested in? So thank you.
Great question, Malcolm, and thank you very much. And can I just acknowledge to the audience the important mentorship that Malcolm Cox has provided to a number of the programs in the United States and Canada that have been looking at this socially accountable, longitudinal, integrated approach that technology enables. And of course, programs like University of British Columbia, NOSM, Northern Ontario School of Medicine, and other fantastic examples, including some of the Francophone universities in Canada. The key, really, to answering your question is that this needs to be driven by communities. This program started in 1997 because I was a rural doctor who lived in rural communities and saw the need and said, not doing anything about this is not good enough. How can I work with like-minded people in my community to do this? The community actually lobbied for the money. So they lobbied the government to get the resources, firstly for the pilot, and then this has now been expanded across the whole of Australia so that 25% of all medical students in Australia now undertake at least a year based in a rural, regional or remote community, using IT as a facilitator to enable them to be outside the main campus. So there's already been a distribution of this sort of model. What there isn't yet is a distribution of the extent to which Flinders has gone, whereby you actually can start your medical course by staying in your community. That is the next stage, and that is what communities are now saying to us. We want to be involved in choosing these students, and we don't want them to have to go down to the city for a couple of years, potentially come back to us, but then have to go back to the city for further postgraduate training. We need to be able to do the postgraduate training here as well, so that they can buy a house here, so that they can find a partner here, they can have a family here, all of those other social things that are so important in career decision making. So the critical thing is working with community leaders, working with local clinicians, and as institutions, enabling them to see that actually the institution can be an enabler to their vision for what they want in terms of their community being part of this.
Okay, thank you. We have a second question, Julian.
Congratulations on the excellent work that you've described. And given how much of our world is truly rural, this is vital work. So our question for you from this table and our discussion is, what projections could you make about how long it will take for information technologies to sort of catch up with our desire to expand learning in these ways. What we see now, we happen to see you very well, which is quite nice. I hope you can see our faces very well. But that's not always the case with information technology connections. Sometimes there are lags between comments and verbalizations. Sometimes the connection drops. You know all the stories. So in order to have reliable, not too costly sorts of connections, what projections might you make for the future?
Well, look, great question. The first thing I'd say is I don't believe that technology is limiting us right now. I think we have the technology, we don't have the will. And we have institutional inertia, which is a force against the democratisation of knowledge and the democratisation of education and health service delivery. There are forces that are maintaining the status quo, and it's not a lack of IT. And I say that because, yes, there are bandwidth issues if you're wanting to use high data, synchronous communication. But most of what we did for the first 10 years was asynchronous. And if you look at the usage of these phones here, there's far more traffic using text messaging than there is using FaceTime. So low bandwidth communication is already being used by generations at the moment, asynchronous, not relying on large amounts of bandwidth. And importantly, technology doesn't mean that if you go to a remote area, you can still access all the experts in the city. And that's what you need for your education. Yes, they are important, and yes, they are experts, but there are also experts locally. And one of the things that our institution, as a research-intensive, quaternary, hospital-based institution, came to realise that there was a great amount of expertise for clinical practice and for education outside the walls of the tertiary quaternary hospital and the university campus. And it was accessing that, linking into that, recognising that, rewarding that expertise that was crucial to the expansion programs. So I actually don't believe that there is an IT block to what we need to do. There's a mind block, and there are reasons why that is. And I also have to say that many of the people who oppose this or have worries about this have worries founded because they're worried about quality. They're worried about the output, the safety of students, the safety of patients. So they have legitimate concerns. The trouble is that those legitimate concerns are based on a skewed view of the evidence and an incomplete understanding of the evidence. And if we can get that message out, then I've found that some of the most ardent critics in our organisation, critics for good reason, have then embraced it and become the advocates and passionate advocates, almost a little bit like ex-smokers. You know, there's no one more passionate about changing cigarette laws than an ex-smoker. A person who's been very much focused on the single institution who catches this vision can be your best advocate.
Thank you. Can we have one question from table 7 or one remark?
Hi, and thank you very much for sharing this incredible model. And this is a question. Are you thinking that in the future it might be, this is a very good example if you can have like interprofessional approach, if you have in your team a public health perspective, and the nurses and the psychologists, I think it's an excellent model for an interprofessional education team. Yeah.
Look, fantastic point. The key, if you are looking at interprofessional learning in rural and remote areas, is that all professions have to be prepared in their accreditation processes to have students supervised by someone outside their discipline at times. Now, in medicine in Australia, we've actually found that quite easy. We have students who are supervised for part of their education by nurses, by OTs, by physios, by audiologists, by speech therapists. But if we try and get a physiotherapy student out there, the association says they have to be supervised by physios the whole time. But we don't have a physio there all the time. We have other members of the team who are equally good at supervising exposure to patients, but we don't have a physio there the whole time in a remote setting. So there are some of those, again, that sort of institutional inertia within our professional bodies that we need to look at overcoming. What you do find, and this is probably the most important point that I can make, is that students are given the opportunity, they will find solutions. They will find ways of creating the education that they need. Now, you can call that self-directed learning, or you can call it empowering students to learn and find meaning in their learning. And they inevitably want to do that together. They want to get together with students of other disciplines. And let's face it, rural and remote practice is a team sport. So it's an ideal opportunity for students to experience that.
Thank you. Paul, we have time for one final question. Table 4, please.
Sure.
Hi, Paul. This is George Tebow, and I've long been an admirer of your work and a fan of the longitudinal integrated clerkship. You already addressed one of the two questions we had, and that is how to make this model interprofessional. But the other question we had is that in addition to producing generalists, the rural areas need specialists too. Can you talk about how this model is useful and what your outcome has been in producing the requisite number of specialists as well to serve the needs of the rural areas?
Yes, look, and thanks. It's great to see and hear you, George. And you also have been an inspiration for many of us who've been looking to get socially accountable, integrated, longitudinal education. So thank you for your part in that. I mentioned that around about 60 to 70% of the students go into primary care. And in Australia, that's a specialty, but I know what you mean. The other 30% don't. And that's really important for us because you're right, we do need the whole variety of specialties. And if I just take medicine, that means the surgeons, physicians, obstetricians, psychiatrists, etc. And we need the whole range of disciplines of different professions. The key there, again, for us has been the integration of both undergraduate and postgraduate training. And this requires, in Australia, it's the colleges, in terms of their accreditation systems, reinforcing the need for generalism within the specialty. So what I mean by that is a general surgeon, a general physician, a general paediatrician, a general psychiatrist, because they are the sort of specialties that are going to be able to meet the needs of people in secondary care hospitals or primary care hospitals far better than a person who only operates on, it'll look like my left shoulder, but I'm actually touching my right shoulder, rather than the knee or the hip. So if we have an orthopaedic surgeon, they need to be someone who is qualified and skilled to do that. In Australia, what we've done is we actually have a college of rural and remote medicine that has been formed, an interdisciplinary college that looks at those generalist skills, not only in the primary care space, where it is really important that you have clinicians who can work across primary care and secondary care, but also in the tertiary specialties so that we can get postgraduate training and undergraduate training occurring in rural areas. There'll always be a need for, in my view, for people who are training in the specialties, say internal medicine or surgery, to have to spend some time in their training back in a large quaternary or tertiary hospital. That's important because it's important that they know where the patients go when they refer them to one of their quaternary colleagues, and they've got those networks and they've got those links and they've had that experience. But that's not the majority of their learning. The majority of their learning has to be enabled again through technology being an enabler, but actually policy being the greatest enabler, to be able to be undertaken in rural and remote settings. So thanks for your question. Great question.
Thank you.
Thank you. I fear, taking a look at the clock, time is running. We have to leave it there. Paul, I would like to thank you very much to be here with us and to bring this extremely interesting input, despite the shooting which must be going on in your background. And
well, what you can't see, and I'll just show you, is that they're actually packing up my table, and mine is the last table in this whole room.
Before they remove you forcefully, I think we stop here. Thank you ever so much.
Pleasure. Goodbye.